Hi, I'm Onda Quo. Thanks so much. It's really just so refreshing to come to this meeting because it's a whole new world for me. And I guess I'll introduce myself briefly. I'm a pediatrician. I'm a professor at UCSF, and I'm clinically based at our public health hospital, San Francisco General Hospital. And we've had this wonderful collaboration for a year now with UCANR, and I'll share a little bit more about why that is so exciting to me. But I'll turn it to Amira first.
Hi, everyone. I'm Amira Resnick. I'm with UC Ag and Natural Resources, UC Cooperative Extension, based in Davis, actually, working at the statewide level as Director of Community Nutrition and Health. So I work closely with our SNAP-Ed program, our FNEP program, in building new activities and collaborations such as the one we're here to talk about today.
Great. So there's so many themes that have already emerged that really resonated with me. And my career has largely been in medical education, especially around advocacy and community partnerships and collaborative leadership and health equity. And one of the articles that I've been using lately is called The Dawn of Systems Leadership, which is in the Stanford Social Innovations Journal. But it talks about, it says, we face a host of systemic challenges beyond the reach of existing institutions and their hierarchical authority structures. The deep changes necessary to accelerate progress against society's most intractable problems require collective leadership, which I feel like I've heard a lot today already. And when I didn't know UCANR existed. And as a UCSF institution, and maybe you all haven't heard of UCSF because it's not one of the undergraduate, graduate UC campuses. It's a specific campus focused on health professions. So super excited to see an institution that we could collaborate with, and also thought about what an incredible opportunity is to leverage our different strengths to improve health and well-being. Okay, so this is what's so powerful, I think, about the collaboration is that we can, UCNR, as you all know, what your expertise is, but from my perspective, the ability or the opportunity to collaborate with trusted community educators and UCNR's expertise, along with our healthcare-focused, health systems-focused areas of expertise and research, is just a super powerful combination. I don't know if you want to add anything.
I'll just add, we've begun collaborating through relationship building, understanding each other's areas of expertise. We have a network of at least 15 or so advisors. We call them advisors or specialists in our that are focused on community nutrition and health. We have about 200 educators throughout the state that we currently work in our SNAP-Ed and FNEP programs. And so our footprint across all 58 states and with an existing presence in 40 counties provides a lot of opportunity for us to reach our current audiences with a different expanded content areas that our UCSF partners can support with their expertise.
So often when we teach in a case-based way. I don't know if that's something that you all use, but I thought I'd walk through. We had earlier, as we've all talked about already, there was such a crisis in mental health that was already existing, and then the pandemic just completely floored us in healthcare and inundated those of us that are not mental health specialists with a lot of needs around mental health. So we had a 3-part symposium webinar series where we were focused on how we in our healthcare system could improve the care we're giving to all the mental health needs we are seeing, no matter where we were, in the ER, in primary care, in subspecialty clinics. So we presented a patient I actually saw in my own clinic, because all of the patients I see, honestly, have mental health needs. And as I said, I'm in a public health hospital, and I imagine a lot of the community members you all interact with also have mental health needs. And as we've talked about, the intersection between social drivers of health and mental health is pretty apparent, I think, to us. So this is a 13-year-old patient I saw. And it was the first time I'm seeing him, even though he was seen throughout our system multiple times. And I'm partly also sharing this because part of what we've been doing is trying to like understand each other's worlds to best see how we can best collaborate. And so if we have a glimpse of somebody in my clinic for like 15 minutes dealing with all these things that emerge of needs, and he goes back out into his community and interfaces with many of our community partners, including all, members of your organization, I feel like if we could collaborate, we'd be better able to carry and support these individuals. So anyway, 13-year-old, lots of visits. And when I usually start my visit and say, tell me what your priorities are for today. And he talked about leg cramps. He's missing a ton of school. He later stated he has daytime sleepiness and he's falling asleep in school all the time. He has poor attention, and he really wanted help with what's called an individualized education plan. He mentioned that he may have had a history of attention deficit disorder. He has a body mass index over 99%, way over. He talked about, I asked, and he said he has daily sugar sweetened beverages, a history of fatty liver. He didn't tell me that. I saw that in the chart. And then he's just clearly depressed. His depression screening, which we do, was really high, and he was just basically in the corner of the room, recessed into himself behind his hoodie, and barely audible when he's talking to me, in a very low-pitched voice. And so I found, we talk about social drivers of health. We screen for some of them. He's in middle school. He says he likes to play video games mostly by himself. He feels lonely. When I asked him what his strength is as a strength-based approach, he says, well, he's nice, but he was really struggling to find anything that he was good at. And it turned out he had moved to San Francisco in 2018. They had fled from Los Angeles from an interpartner violence situation. He'd been verbally abused by a relative and had received therapy for that. And he lives with his mom and stepfather now, whose preferred language is Spanish. And both came to the visit and were very supportive. And we do screen for food and housing insecurity, which they did not have. And then there was also no family history of depression. So I'm just presenting that because we have like 15, I have actually 20 minutes, which is a luxury, to manage all of this. And the first time I'm seeing him. And so the opportunity to collaborate is really necessary because we can't provide everything in that brief visit. And sometimes I feel like we're handing out brochures and I have no idea if they're going to actually connect with resources. Could be referring them to programs you all run, and I just don't know, what's going to happen on the other end. And it's hard for the people walking through our systems, as you probably already know. I think, yeah. So when we think about our collaborative, I hold these patients in my mind as to like what the opportunities are.
So imagining that Dr. Ko's patients is essentially the same audience that we're trying to serve our public in California with all of our programs, we discussed trying to align around common language. And so the theme of our partnership broadly is around health equity, and realizing within our division at ANR that we had not yet come together as a team. I mentioned all those folks prior around what is health equity, how do we think about it, how do we practice it within cooperative extension. Everyone's doing it in their own way, or many people are focused on these areas and this value system or set of practices, but we decided it was important to come together on a series of 3 trainings that we co-hosted, and started with identifying a shared language around what health equity is, addressing what ANR is currently doing in this area, and then discussing new areas and new approaches. So really grounding in the themes and concepts of health equity as a beginning place for this work.
I'll, in the interest of time, I won't spend a ton of time on this slide because you've already seen some data around this, but when this data came out, it really validated the experience a lot of us were having in the healthcare area. So you can see this incredible uptick during the pandemic of seriously considered attempting suicide among US high school students by sex, and it's from 2011 to 2021. And then this bottom one, persistent feelings of sadness or hopelessness. And these are the more extreme measures of mental health indicators for youth, and they were just skyrocketing. And then the last graph over here I'll just mention is just making, again, the link between income and social emotional distress, which is SED. Yeah, I think that's all I'll say there.
I was really glad as we're bringing our network, our team across the state together, that we had the National Framework of Health Equity to lean into and get grounded in. For me, that was very refreshing. I've been in my role for less than 2 years, new to cooperative extension, and I was delighted that this existed because we didn't have to make the rationale. We didn't have to create the justification. It's already there. And so, all of us in this room are working across cooperative extension in this direction. And so that felt very supportive to be able to, when in doubt, be like, turn to the framework. And so we grounded in the social determinants of health, as you're probably familiar with in this framework, in this paradigm. And then we did spend one of our sessions going deeper into that left-hand list of strategies or approaches in health equity. So just lifting this up because it's been very helpful for us. Should I go on? We also, within our network, a few of our advisors created a logic model for us, and in terms of the direction we want to go with our expanded scope of work in public health and community health. And so we're talking more about these 4 domains of health: physical health, psychosocial health, environmental health, and economic health. We had the chance to get together this past April, over 150 of us in the same room. Dr. Ko was there with a colleague. And we generated a lot of input from across our team of educators and advisors to explore the areas of opportunity that we want to work into. And so for me, this leading question on the slide around how can we co-create responsive programming with community partners to address more broadly these 4 domains of health, for me represented what I'm hoping can be a paradigm shift in our programming, where we're really trying to be even more responsive and develop programming, knowing the interests and priorities and needs that our community members are sharing with us.
Okay, so this has been a year-long dive into each other's worlds, and so we've shared some common language and understanding and implemented different forms of some more informal needs assessments. And so looking ahead, like what's on the horizon for us, for one, we identified areas of need for resources, and this includes things around chronic disease prevention, including mental health, and also people asked for, that health equity framework, and we did the brainstorming, and they wanted to know, like, where are the resources to help us implement some of those health equity recommendations. So by co-developing resources, we can bring our 2 areas of expertise together based on evidence. And for me, as I mentioned, just super excited for the UCANR partnership and their trusted community educators throughout the state, which is just such that kind of ability to reach with certain health messaging to communities is really powerful, because I feel like we're very siloed off in the healthcare world. And then the second thing I just want to briefly mention is one of our colleagues, Dr. Kevin Grumbach, he was involved with the writing of the Affordable Care Act. And he included in there a model of primary care based on the cooperative extension as a powerful model. And so to basically have like a dissemination of evidence-based practices through primary care based on the model that you all have. It was put into the ACA, it wasn't funded, so it never actually fully got developed. But that idea, I think, is still really powerful, and for me in a different way, in that we wouldn't necessarily see it as a primary care extension model, but to partner around health and well-being with cooperative extension. And California has a huge movement behind behavioral health. There's several pediatricians and other physicians in place who have put in funding mechanisms to expand our provider class for who can bill for Medi-Cal. So that means that if we can create partnerships, for example, with cooperative extension educators to be community health workers, or one of those extended classes of healthcare providers and educators, we can find sustainable ways to continue that position by using and leveraging the Medi-Cal dollars that are coming down from the state. Implementation is challenging, but that's something that I've been focused on in a variety of other projects. And so very excited about that possibility, of course, further out. I just want to briefly mention, this keeps coming up to me like, wow, how powerful this could be, because I, as a provider, was very scared about asking about trauma because I wasn't trained in trauma-informed practices and how to respond. This is a tool that we've developed. I was co-director for a California Learning Collaborative focused on adverse childhood experiences. And it was about inquiry and response, implementing that throughout primary care in California. So Dr. Alicia Lieberman, who's spent her whole career on child-parent psychotherapy and built the evidence base for that, we created this tool that busy practitioners could use to bring in those child-parent psychotherapy model into our practice. And I use it every day when I talk to my patients, because inevitably mental health is impacting their well-being and physical health. And so if I don't ask about it, I can't do anything about it. So I just put this up there because there's some resources there that might be interesting, but I could imagine like a trauma-informed cooperative extension, and maybe that's already happening, I don't know, but something like that, because I'm sure that a lot of the community members, again, are impacted by trauma, given the numbers that we know exist. Okay, I know we're out of time, so just mentioning what the CDC laid out for their key strategies to improve youth health and well-being, increasing the sense among all students that they're cared for, supported, and belong at school. That was one of the major differences in that youth behavioral study that annual that we're pulling the data from, that showed that there was a difference if they felt connected to their schools. And then increasing access to needed health services, which is where our partnership could be powerful, and implementing quality health education, also a really great opportunity for our collaboration between healthcare and cooperative extension. We have a great team. Amira, I don't know if you want to say anything about your wonderful team.
Just that we've been leveraging our network of advisors, and specialists, and these are some of the folks that have been most involved in supporting this collaboration.
And same on the UCSF side, across the age spectrum, family medicine, internal medicine, pediatrics. That's it. Thank you.